The American Liver Foundation's mission is to promote education, advocacy, support services, and research for the prevention, treatment, and cure of liver disease. There are 18 divisions of the American Liver Foundation throughout the United States. The Connecticut division is based in North Haven, Connecticut, and provides education, resources, and advocacy to over 5,000 people each year. We are pleased to present this webinar featuring Dr. AnnMarie Liapakis, a transplant hepatologist at Yale New Haven Hospital Transplantation Center and Yale New Haven School of Medicine. She is a graduate of Fordham University. She completed fellowships at New York Presbyterian, Columbia University College of Physicians and Surgeons, and New York Presbyterian Weill Cornell Medical Center. She did her residency at the Mount Sinai Hospital in New York. Dr. Liapakis is on the board of directors of the American Liver Foundation's Connecticut division, and she also serves on its medical advisory committee. Dr. Liapakis will provide very useful information about liver disease, liver donation, and transplantation. We welcome Dr. Liapakis.
Thank you, Donna, for that very kind introduction. I'm very happy to be working with the American Liver Foundation to provide education to the medical community and, most importantly, to our patients and their support system so that they are better able to partner with us in their care and advocate for themselves. I'm excited to speak about living donor liver transplant today, as I see it as an opportunity to provide a cure for our patients suffering from end-stage liver disease. I'm also very proud that as a transplant community, we are able to offer this therapy through a comprehensive multidisciplinary care model, meaning many members of the team coming and working together. I'm blessed working as a transplant hepatologist that I'm reminded via organ donation, be it deceased or living donor, that humanity is good and that through altruism, dedication, and skill, miracles can happen. Living organ donors are true heroes, and it is a pleasure to work with them. I've outlined my talk to begin by providing a context for living donor liver transplant via a review of the natural history or progression of liver disease and the indications or reasons why a person may need transplantation in general. I'll then aim to define the role for living donor liver transplant. I'll describe the surgical procedure and discuss transplant outcomes. I will then spend the remainder of our time today discussing the liver donor process with attention to the evaluation and advocacy, donation and recovery, and long-term follow-up. Unfortunately, there are many myths and misinformation surrounding liver disease and transplantation. I would therefore like to begin by providing some definitions, describing the natural history of liver disease, and potentially dispelling some of those myths. Hepatitis means nothing more than liver inflammation. Sometimes I fear that when people hear hepatitis, they assume that it means all sorts of craziness like drug use or alcoholism or STD, and that's just not true. Hepatitis means nothing more than liver inflammation, and it can have many different causes. I've outlined some of those on the slide, such as viral infections, immune disorders, genetic or inherited conditions, alcohol, fatty liver disease, and sometimes even heart disease. But whatever it is that's causing liver inflammation, if it goes on over time, it can lead to the development of scarring. I think of it as if someone's scratching their skin from irritation and they scratch, they're going to develop scarring. It's that same sort of process in the liver. The fancy word that we use for scarring is fibrosis, and a person may have no fibrosis or scarring, which is normal, but as disease progresses, they may develop a mild amount of scarring, moderate, and then, of course, more advanced. When the liver becomes very scarred, that's when we use the term cirrhosis. So cirrhosis means nothing more than a very scarred liver. Sometimes when a person has cirrhosis, the liver may still work normally, but if the disease progresses, then the process can worsen and a person may begin to suffer with complications from their liver disease. So I've outlined here the stages of cirrhosis. I just mentioned compensated means that the liver is scarred but still working well and a patient may have no symptoms. However, if the disease progresses, then their life and their day-to-day activity may be affected by their liver disease. And the way that I think of it is there are three things that may happen. And it may be just one of them, but it may be all three. And I'm going to take a moment now to go through each of these because they are really the reasons why a person may need to be considered for a liver transplant. So the first is liver dysfunction. That means that the liver is no longer doing its job 100%. And the liver does a number of important things for the body. It makes proteins, and those proteins are used to build muscle mass. We can actually measure one of those in the blood test. It's called albumin. The liver also makes a lot of proteins to help in blood clotting. So if someone cuts themselves, they're bleeding, they ultimately form a blood clot. It's the liver that's done a lot of that work to make the clot. So when patient has liver dysfunction, then they may have easy bleeding. It may take longer for their blood to clot, and we can measure that too by something called INR in the blood work. The liver makes bile that flows through to the gallbladder and then is used to be delivered to the intestine to digest fats. And when the liver is not working well, that bile may build up. A person may become yellow with jaundice, and you can see that in their eyes or their skin. And we can measure the bilirubin too in their blood work. The liver stores sugar when person's fasting, and so they may have trouble with low blood sugar when the liver is not working well. And the liver works as a part of the immune system, and we see that our patients with advanced liver disease suffer from more frequent infections. In transplant, we use a scoring system called MELD, or Model for End-Stage Liver Disease. Really, it's MELD sodium, but we'll focus on MELD today. And this is meant to objectively capture how sick a person is related to their liver disease. It's a math formula that uses the patient's lab results. Those labs are bilirubin and INR for the reasons that I just mentioned. Also creatinine, which looks at kidney function. Sometimes when the liver is so sick, the kidneys can become sick too. And then also the blood sodium level. You can Google MELD calculator and put in the lab results, and it will report back a score. This is used on the transplantation websites as well. The results range from 6 as the lowest, and that indicates the healthiest person. Because of the formula, the score can't be lower than that. And then up to 40, which is the cap on the transplant waiting list, and that reflects the sickest person. Though the score can result higher by the formula, it's capped at 40 on the transplant waiting list. So MELD score is associated with the risk of dying from liver disease. For example, a person with a MELD score of 40 generally has near 100% risk of death over a 3-month time period. Patients are ranked on the waiting list by their score because, of course, we want the sickest patients to get transplanted first to reduce the risk of people dying while waiting. The liver wait list has nothing to do with waiting time for priority. Data that we've collected as a medical community from experience and study has shown that generally a score of about 15 is the point where patients do better with than without a transplant. So sometimes patients whose scores are less than 15, whose livers are still hanging on, able to work to some degree, they may do better holding off from a transplant at that point unless something gets worse. Whereas 15 and above, we generally see that people benefit from transplant. Unfortunately, there is a set of patients whose MELD score may not accurately reflect how sick they are. So that means their score, for example, may be lower, like 10, but yet their life and the risk to their life, their quality of life, is really much higher than their score would predict. And I'll go on to explain why that may be, because patients who fall within that category may be a subset who really see a significant benefit from pursuing living donor liver transplant. So I mentioned and went through now liver dysfunction. I'm going to move on to portal hypertension. And what that means is it really means a high blood pressure around the liver. I like to use an analogy of a traffic jam to describe this. So let's imagine you're driving on the roadways and you come upon a traffic jam. What happens? The roads are congested and the cars start backing up into the incoming roadways. The tension is high. people get frustrated. They try to get off the road and find another route around. Um, and that's essentially what's happening in and around the liver when we see a high pressure or, as I said, portal hypertension. So the liver is positioned on the right side of the body, and blood leaving the liver ultimately travels back to the heart and is pumped out. Blood from the lower part of the body and the intestines has to travel through the liver to get there because, of course, blood flow through the body is in a circuit. So I think about the scarred liver with a high pressure like a traffic jam. The blood is trying to come into the liver, but it can't flow as well because of the scar tissue. And so the blood backs up into the incoming veins just the way the cars would back up in traffic. And the tension in those veins is high. And believe it or not, the body is able to divert blood flow away and around the liver by forming new blood vessels that otherwise wouldn't be there. And we see that as a result of that, our patients can develop varicose veins in the food pipe or esophagus, in the stomach or intestine, and those are called varices, and they're under higher pressure and may be a risk for bleeding. Because of that pressure and because the liver is not working well, people can also develop fluid buildup in their belly, what we call ascites. And because some of the blood is not being diverted, not traveling through the liver and being cleansed well, people may suffer from a buildup of toxins. One of those is called ammonia, not pneumonia, ammonia, and that can lead to cloudiness in the thinking and confusion, and at a more significant degree, coma. So some of our patients with this scenario, with a high pressure around their liver, but fairly intact liver function, their score may not show how sick they are because they may be having bleeding episodes, fluid buildup, confusion. We use medications and sometimes endoscopy procedures to handle this, but there becomes a point where we may not be able to do so. Another thing, or the third thing that I mentioned that may happen, is that a person with cirrhosis may develop a liver cancer because it occurs more commonly in the scarred liver. And for liver cancer within certain criteria, transplant may be offered as a potential curative treatment. So I'll just summarize now that the reasons why a person may need to pursue liver transplant can be that the liver is not working well, that they have a high pressure around the liver from the scarring, leading to complications like bleeding, fluid buildup, and confusion, not managed well with medicines, or develop a liver cancer. There are other more specific, less common scenarios, such as metabolic disease that we won't cover today, that patients may benefit from transplantation. So as we discussed, the MELD score is based on lab results and reflects how a person is doing. Therefore, it's not static. It doesn't stay at the same number. It changes with the patient's course and their disease process. But unfortunately, this is not predictable. And I often worry that patients and their care providers may falsely believe that their MELD will go up in a stepwise fashion. So, for example, they may think that the MELD would be 8, and then 12, and 15, 20, 25, 30. And just when they're about to fall off the cliff and get really sick, that's when they start thinking about transplant. But that's not the right way to approach it because, unfortunately, liver disease is not predictable. Unfortunately, patients with liver disease are fragile and vulnerable, and their course is often marked by acute complications, which may include bleeding, infection, confusion, hospital stays, and they may not recover to their prior level when they suffer one of these episodes, and they may become sick very quickly. As a result of this, currently in our region, located in Connecticut right now, about 1 in 5 patients may miss the opportunity and die before they get to transplant. And so the key and one of my main messages today is if transplant is indicated, if a patient meets criteria to be considered for transplant, the goal should be to move forward as quickly as possible to achieve transplant and avoid this roller coaster ride of complications. It can be a challenge for medical providers and patients to understand this. I think in general, people seem to understand cancer as a risk to their health, but they may not view a chronic illness in the same way. Examples of such may be heart failure, chronic lung disease, and of course, what we're talking about today, chronic or advanced end stage liver disease. And I thought that this study is important because it provides a review of illnesses that are not cancer that have an impact to a patient's life and affect their survival, that they may be limited to 6 months or less. And what they found when they looked at patients with liver disease was that if they had advanced disease with the complications we're talking about and a MELD score of 21 or more, their life was at risk significantly, with a predicted median survival of less than 6 months. If they were hospitalized with one of the complications that I mentioned and their score was 18 or more, they fell into that same category. So, again, we need to recognize this and pursue transplant as a potential curative treatment. The goal of transplant is to restore patients to health and to provide a long-term survival. And that's what we aim for our patients. We want to see them undergo transplant operation and have close follow-up. Of course, it requires medications to prevent rejection of the new liver and long-term care with transplant team. But our patients are expected to do really well post-transplant. And we see that due to these comprehensive care teams focused on detail and improvements in the medications that prevent rejection over time. In the U.S., transplant outcomes are tracked and reported for public access on a web called the SRTR, Scientific Registry for Transplant Recipients. And transplant centers are evaluated, and they can be cited if their outcomes for patients are less than expected. And so it's very a rigorous program to make sure that patients are benefiting from their transplants. 1 year survival for liver transplant is well over 90% at this point. And we have patients now who are transplanted in the early days of transplantation in the late 80s that are living now beyond 20 and even 30 years. So this is what we aim for our patients with end-stage liver disease. Of course, transplant is not perfect. There are potential complications, and I just point out some here. This is not the focus for today, but sometimes we see that the liver is not working well early on, or they're bleeding or clot complication, bile duct issues. But we're often very effective at being able to address these issues and, again, get patients to benefit for many years from their transplant operation and care. Unfortunately, we're at a time where the organ shortage is significant. This is a graphic that looks at the number of patients added to the solid organ waiting list in the United States, and what you can see, the orange bar, is that this is increasing over time. Down below, what you see is the number of donors recovered, or the organs that are available for transplant, in blue, and the number of transplant performed in green, and unfortunately that's static. So we're seeing an increase in the need for transplant, but not necessarily an increase in the supply. When I looked at the numbers yesterday on the Organ Procurement and Transplantation Network in the United States, 13,413 patients were on the liver waiting list awaiting transplantation. So we have to be aggressive, and we have to be proactive in terms of expanding transplant access for our patients. There are ways that we do that looking at deceased donors, such as splitting the liver to be received by both an adult and pediatric patient, looking at certain criteria of the organs and expanding use. But the main focus for today and what I want to highlight is the opportunity for living donor liver transplantation. Living donor liver transplantation may provide a timely transplant for patients. And I'm going to now shift to using the remainder of the time to describe the living donor transplant process and then the evaluation of our donors and long-term follow-up. So living donor liver transplant involves taking a portion of the liver from a healthy living donor and sewing sewing it into a recipient after their sick liver is removed. Living donor liver transplant was prompted by the shortage of organs for use in liver transplantation. And actually, the first report of successful living donor liver transplant was performed at the University of Chicago in November of 1989, when a 2-year-old recipient received a portion of her mother's liver. Although initially utilized for pediatric recipients, surgeons subsequently developed techniques for successful adult-to-adult living donor liver transplant. It's technically more complicated than a deceased whole donor transplant, and so it's performed at select number of specialized centers who have a living donor program. The reason why we're able to do this is because the liver is one organ that has a segmental anatomy, so that means it's divided into pieces that each have their own sort of supply from artery, vein, branch, and bile duct. And the liver has the amazing capacity to regenerate or grow so that it may grow to full size in the donor and recipient after donation, surgery, and transplant in about 6 to 8 weeks. It doesn't develop the same exact pattern, but the lobe that remains basically increases its size. And the recipient has to be able to tolerate this period of growth. So the person who receives that organ has to withstand that period of regeneration. And so our sickest patients on the waiting list are not eligible for a living donor liver transplant. And so we need to think about this early so that we don't miss an opportunity for them. The ideal MELD sodium per transplant is about 15 to 25. We have been able to go higher, taking in special considerations and care. And as I said, there are patients whose MELD score are less than 15 who may be suffering from portal hypertension and its complications, or liver cancer, or quality of life issues that benefit at a lower MELD. So I want to speak briefly about the surgical considerations. So there are different types of liver segments, or the graft. That means which portion of the liver is removed and given to the recipient. And that may be right lobe, left lobe, or a smaller piece, what we call the left lateral segment. For most people, the right lobe, actually for all people, the right lobe makes up the larger portion of liver volume, generally about 60%, and left lobe 40%. Most adult living donor liver transplants in the U.S. are right lobe, but there is a possibility for left lobe donation and transplant with smaller recipients or larger donors. And then adult to pediatric recipients may be left lateral segment. If we're going to remove the right lobe from a donor, we need to make sure that their left lobe makes up at least 30% of their total liver volume, or else we say that it's not safe and it's not possible and they can't be a donor. When we look at how the piece of liver, whether it will be enough for the recipient, we do a ratio of the volume of that liver piece to that person's body size, and it should be 0.8% or more. We aim for 1% usually or more. So if you were to open up a textbook, you would see a picture of how the liver is made up in the different segments and how the veins, arteries, and bile ducts run through it. However, it's very rare for a patient to look exactly, or a donor, I should say, to look exactly like the textbook. And so we need to pay special attention to how the vessels are running through that donor's liver and the branching pattern. And we look at that information with the radiologist, who provide us with images that I'm going to show you in a second, and the surgeons, because then the surgeons plan in advance how they're going to divide the vessels and how they're going to sew the connections to put the new liver in. So thankfully, CAT scan and MR imaging has come a long way, and we're able to really get very detailed views to make these roadmaps in preparation for the donation, surgery, and transplant. And this is an example of CT image showing the liver in the body, and the green line represents the surgical planning of where the division will be made. We're also able to get very pretty pictures in 3D imaging that give us a real great branching pattern an assessment of the liver lobes. And here what I'm showing is a comparison of what the radiologists estimate, and then when the surgeons do the procedure, what the size is. So they take volume measurements and what the difference is. So these techniques are very accurate, and most often the difference is less than or equal to 8% for all living donor cases, and that's between what the radiology test beforehand had estimated and what they truly find at the time of the donation and transplantation. And we use this to plan carefully and protect our donors. So I'm just going to highlight again what are the advantages of living donor liver transplant for our recipients. Well, the most significant thing is a decreased waiting time so that the recipient is less sick at the time of surgery, which allows for a less complicated recovery and hospital stay, and that the transplant can be timed based upon their need and reduce the risk of death on the waiting list. Living donor grafts are generally a better quality because they're coming from young, healthy donors that have been evaluated intensely before the donation, and there's no damage to the liver related to donor death that we see through deceased organ transplantation and the travel time that it takes to bring the organ to the transplant center. For living donor liver transplant, the donation operation and the transplantation or sewing in the graft usually happen in operating rooms that are in the same hallway, if not next to each other. I will mention that there is a separate team of surgeons dedicated to the donor and the recipient. So what we see in transplantation and what this graph is meant to illustrate is that the outcomes from living donor liver transplant are somewhat better than the outcomes for patients with deceased donor transplantation. And this graph is looking at that over time. Of course, if a patient has the opportunity for living donor liver transplant, that significantly reduces their risk of dying on the wait list. And this is a graph from a group called A2All that looks at outcomes of living donor transplant across the United States together. So what they showed that compared to a patient who remained on the waiting list, which is the gray line, patients who underwent transplant obviously did better. And what they saw was that patients who had living donor liver transplant at transplant centers that have done more than 20 living donor transplants, their outcomes were better than deceased donor transplant. So we do say that experience matters, and it is important to seek care at a living donor certified transplant center and to discuss experience. Blessed to be able to work currently at Yale New Haven Hospital, where our transplant surgeons each have a few hundred living donor liver transplant experience. So I'm going to mention a little bit about what are the potential complications of living donor transplant for the recipient or the patient that receives the donor graft. So one of our transplant surgeons, Danny Hackinson, uses this graphic to explain, and I thought it was really great. If you look at the tree and you think about transplant, if you're doing a deceased donor transplant, you're sewing in the whole liver really at the trunk, at the main points of the bile ducts, arteries, and veins. But if you're doing a living donor liver transplant, you're using a smaller portion of the liver that's been divided, and you're sewing it in at those smaller, finer branches. So the things that we see more commonly with living donor liver transplant relate to that. There's some higher risk for bile duct issues, a stricture or a leak, where the bile duct is narrowed and may need stenting, or a leak where there's some bile leaking out, and that could also need stenting to repair it, or for the potential of a problem with the blood vessels. And there may be more increased risk for biliary infections or bacteria coming from the bile ducts. Whereas we look at complications from deceased donor transplant, what we see is higher complications that are associated with the patients having to be so sick before they get to transplant. So things like fluid buildup in their lungs or their belly, potential heart problems, or bleeding episodes. Um, so we're aware of this, and we take special caution to look out for complications and address them immediately in the post-transplant period. So I'm going to shift gears now to the donor evaluation. So we encourage our patients on the liver transplant waiting list to talk about their need for transplant, to share their story, and we provide specialized education about that, and we help them to overcome some of the maybe trepidation to sharing their story and reaching out for help. And so we hope to see people calling in to be considered or coming through the website to be considered as potential living donors. We also see that people who have an interest in just helping in their community and helping other people may call to learn about living donation. We tell our patients not to pre-screen donors. That's our job. We go through a very extensive process to make sure that donation would be safe for patients and that, safe for the donors, and that is the right thing to do. Only about 1 in 5 donors is ultimately approved to go on to have the donation surgery. So we encourage people to really spread the word widely, and we let people who are calling as donors know that so that they have a realistic expectation going through the process. Even if a donor is not approved to go through surgery and be the one that gives the piece of liver, there's always something that they can do to help. We say that coming to learn about liver disease and transplant allows them to then be a voice to go back to the community to spread the word. They can serve as an advocate for the patients. And so it's always of value for someone to call to learn about donation. We will do the testing for compatible blood type. We don't require that people know their blood type before calling in. And we're often asked, who can be a living liver donor? Do they have to be related? No, they don't. Actually, anybody can come forward as a potential donor for a patient. They don't have to have a direct relationship. They can be a blood relative. They can be a friend. They can know them through the community or through their church or temple or whatever it may be. And they may also be what we call non-directed or truly altruistic, where they have no connection to the intended recipient. The key really is good health, and it's our job to ensure that that is assessed prior to the donation surgery. So we want people who are contemplating donation to know that we feel the decision needs to be informed. We want potential donors to have all the information that they need about the process to make a well-informed decision, basically. We aim to strive to ensure that they are free of pressure and that there's been no coercion, either by the patient, family, friends, community, or the transplantation center. And there is actually, legal protection for that. We make it very clear to donors that they have the right to opt out or withdraw at any point along the process, including on the way to the operating room, and we accept that. And we can give a general statement of unsuitability that this is not safe, they're not able to proceed. We do not relay details to the intended recipient as to reason for decline unless the potential donor asks us that they would like us to do that. The process is very comprehensive. It begins with either web intake or a phone call for pre-screening. Potential donors provide demographic information, basic information about their height and weight. They go through a health screening with one of our nurse coordinators. And if there's something obvious that is going to increase their risk, then they may be excluded at that point. I'll pause here and say that our real priority is to make sure that there's nothing unique to that potential donor that increases their risk above the baseline for donation. We know that there's some risk associated with any medical procedure, with any surgery. We know what the potential complications are. We relay that. We take every step to minimize it. But then we do really, the donor evaluation is meant to take a very in-depth look at the donor to ensure that there's nothing about them or their situation that increases the risk. And if there is, then we state that it's not safe to proceed, because this is a very unique scenario where someone is coming forward to help somebody else. And we see it as our role to make that happen if they want to, but not at any increased risk to them. So if a person is able to complete the pre-screen and considered potentially eligible, then we invite them to do labs to check and confirm their blood type, check their liver panel to make sure there's no elevation, and then if there's something that we need to look into further based on their specific history, we may do that. If their blood type is compatible and their liver panel is normal, they're then invited to come for a full evaluation. At Yale, we have that set up as a 2-day donor evaluation clinic, and patients, donors come. They hear an education session that describes the process, sort of similar to some of the information that we're reviewing today, and then they go through the testing. I'm going to outline that in more detail in the next slide. After the evaluation is completed, they're brought for discussion at what we call the donor advocacy panel. They're not physically there, but we meet as a transplant team and we review their history and the results of testing, and we make a decision as to whether it's safe for them to be considered. If it's safe and they're approved and they want to continue, then we schedule the surgery. They go through the donation, the recipient has their transplant, and then we move on to the follow-up, which includes getting them through the immediate postoperative recovery. So they come to the clinic and meet with the surgeons just as anybody else who's had an operation would, until the surgeon feels that the wound is healed and they're stable. After that point, we see them at 6 months, 12 months, and 1 year. We have also instituted a 3-month follow-up call to screen for any issues related to depression, anxiety, because that seems to be a vulnerable point. And we have committed to extend follow-up beyond the 2-year mark. We aim to check in with our donors every year, and that need not be an in-person visit if that's inconvenient. We work with their primary care providers, and we review lab tests from afar. And our Center for Living Organ Donors has outreach sessions in the community in our region where prior donors may come and receive health screening, for example, blood pressure monitoring, etc., and educational sessions and discussion with other donors. And then they serve as a support for future donors. So what is the medical evaluation of the donor? Well, it's a physical exam and extensive blood work that's aimed to look at overall health, how the liver works, how the kidneys work, prior exposure to infections, a focus on whether there's anything that indicates a higher risk for blood clotting and certain hormone levels. Then we assess the heart and lungs. We get chest x-ray, EKG to look for any evidence of an arrhythmia. That's the test with electrodes stuck on in a red and white printout of heart rhythm. We do echocardiogram, which is ultrasound of the heart with the jelly and the probe looking at how the heart pumps and looking at the valves. We do liver imaging, as I mentioned, CAT scan and MRI. We went through that. If there's any abnormality noted on liver blood work or concern by history or the imaging, then we move to a liver biopsy to investigate further. We don't require biopsy of all of our potential donors. We require that health maintenance testing for all donors is up to date because we don't want to miss an opportunity for them to have appropriate screening for their own health, but also because it would be a tragedy to transmit a cancer to a recipient unintentionally. So we collect their health maintenance records. Donors meet with the members of our team, living donor coordinator, hepatologist, which is the medical liver doctor, who really serves more as a primary provider in that role, doing an intensive history and physical exam. They meet with the transplant surgeon who would do the operation. our psychologist and psychiatrist if needed. Everyone meets with psychology. If there's any concern or desire, they meet with psychiatry. The pharmacist, dietitian, and heart doctor who reviews their heart testing. They undergo psychosocial evaluation, as I mentioned, and what's considered is family history, support network, impact to their job, how this will affect their finances, mental health, understand their motivation and decision making. And we feel that this is very important because just as we don't want to take any increased physical risk for potential donors, we don't want to put them through a donation surgery if that's going to tip off the balance in their life overall, that will have a negative consequence for them. Each donor is assigned an independent living donor advocate who meets with all living donor candidates and contributes to their perspective to donor advocacy panel. The role of the ILDA is to be independent of the transplant center and advocate and promote the donor's interests throughout the process. So to summarize, potential donors receive education, go through evaluation and testing. They're presented at the donor advocacy panel and then notified of a decision. If it's not safe, it would be declined. If it's thought to be safe, they would be approved, and then they make the decision. And if there's something that needs further investigation, we may defer and then review again when we have that information. The things that are considered at that meeting where the donor is reviewed is, as I mentioned, the liver anatomy, lab testing, and history, social circumstance. Common reasons for possibly being declined relate to liver size, the mapping of the arteries, bile ducts, and veins, and then any medical condition that increases risk for the OR. And if we feel they don't understand and are not making an informed decision, and we require all donors to have health insurance to assure follow-up. What donors expect after their donation surgery, they're monitored very closely in the intensive care unit for 24 hours. This is a healthy person undergoing surgery, so the main priority is to keep a close eye and make sure nothing has gone wrong. So they have a special line to measure their blood pressure continuously, a catheter in the bladder to measure output. They have a tube from the nose to the stomach to make sure that they're not at risk for vomiting while their gut starts waking up and working again from the sort of stun from the surgery. Very precise pain management, advancing their diet as they're tolerated. We get people up and walking and in motion quickly. As we see that they're stable, we remove these things, and patients are often leaving the ICU with just IV lines within 24 to 48 hours. We expect them to stay in the hospital for about 5 to 7 days. The road to recovery varies from person to person. We advise no heavy lifting for 6 to 8 weeks, preferably 3 months. We tell people to expect to be tired. The liver is regenerating. That's a stress on the body. We want people to be able to take it easy. We encourage daily walking and return to activities as tolerated. We advise donors to plan to take off 6 to 8 weeks of work, but to allow for potentially up to 3 months if needed. It depends, of course, on the work that they're doing. If they're working on a computer, they may be able to do that very quickly within first few weeks, whereas if they're doing manual labor, we obviously encourage more time off. Donors need to be able to come for clinic visits, but there's no special diet or long-term medications. Once the donor recovers, they return to their normal life, and we follow long-term health monitoring. So the main question that our waitlist candidates have and that we have for our donors is, will they be okay? We want to assure that. So we have to make sure to pay attention to potential risks. The risks for any surgery apply, and those are bleeding, infection, blood clot, formation of scar tissue, potentially a hernia where there's a weakness in the muscle, not being able to urinate readily right away, or infection in the hospital, constipation. Small things are common, so having a bit of constipation may be common, but very bad things are very rare. And so this is what we relay to our potential donors. There are risks specific to donation. As I mentioned, those often relate to the bile ducts or blood vessels. The risk for liver failure in a donor is very rare, but is something that we mention. If a liver donor is ever left with a liver volume that's not working well enough for them, and we see that in their post-donation, then they are actually listed with priority on the transplant waiting list. That does not happen commonly, but that safety net exists. There have been very few donor deaths across the U.S. It's at much less than 1%, and our surgeons discuss the circumstances surrounding those incidents with our potential donors. Thankfully, we've been blessed never to have experienced that at our center. But we make people aware. There are advantages to living donors. They get a very thorough evaluation, long-term medical care. If somebody ever asks, give me the full body check, the donor evaluation is that. It's a comprehensive look at their health. They provide the opportunity to save the life of a loved one. And we have to remember when somebody donates and saves a person on the transplant list, they also open up an opportunity for someone else waiting to receive a deceased donor graft. Quality of life post-donation is great. Many donors present an increased self-worth and personal growth. There's overall lower rates of depression, alcohol abuse, anxiety, though we do see that some donors go through periods where they may have impaired sense of well-being, and we've instituted a 3-month check for depression and anxiety because of that. Negative consequence to the donor may be associated with the recipient's outcome, and so we're very cautious to pay attention to that and provide support. So just to turn to the logistics of donation before we wrap up, these are common questions that we get at the Transplant Center. The donor does not pay for the evaluation, surgery, or follow-up care. This is generally covered by the recipient's insurance. There are some costs that a donor may incur, such as lost wages, travel, lodging, child care, and there are resources available to offset those costs. There are formal assistance programs such as the National Living Donor Assistance Center. The State of Connecticut provides some support for state employees. And our social work team provides guidance on appropriate ways to fundraise. So in conclusion, living donor liver transplant can provide patients the opportunity for a timely life-saving transplant. Living donor liver transplant can be performed safely for donors and recipients at experienced transplantation centers. Living donor evaluations need to be appropriately thorough and care maps precise so we as a medical community assure that we're protecting our donors to the best of our ability and assure positive transplant outcomes. And we really do view living donors as true heroes and thank them for their gift of life. Thank you very much. It's been a pleasure to speak on behalf of the American Liver Foundation today.
Thank you, Dr. Liapakis. That was an incredibly informative session. I think people really are going to have a better understanding of the entire scope of this topic thanks to you. I do want to point to these resources that we offer to people. We have a local website, a national website, a national helpline, educational materials, and in addition, there's online organ donation information. We want to greatly thank you for your time, and also thanks again to our sponsor, Yale New Haven Health, Yale New Haven Hospital. Very much appreciated this support. Thank you so much.
Thank you. It's my pleasure. Hello?